Information is key to patient engagement. We live in an era where information can be shared electronically in an instant, usually for good, not always. And yet here in Canada, patient access to even their own medical records remains difficult. Technology solutions, from personal health records to online prescriptions and appointments, have yet to become commonplace in our system. In his work as Vice President of Global Practice at CGI, our next speaker, Mr. Ed Percy, has gathered an international perspective on legislation governing ownership of and access to medical records. These regulations determine how easily medical health information can be shared between hospital, community, and family caregivers, and how much information patients themselves can have in managing their own health conditions. So in this second transatlantic contribution to our program, Mr. Percy will bring us his view of how this challenge, which is intimately linked to the challenge of privacy and data protection, is being tackled in some of the most advanced countries in terms of health information technology in Europe. Please welcome Mr. Percy.
Je suis content d'être là et merci de m'inviter à vous parler. And I promise I won't impose my rotten French on you anymore this morning. A couple of observations I've really enjoyed this morning. To look at best practice design around oncology, I invite you to look at the Macmillan Cancer Centre at the University College Hospital of London, where they have redesigned an entire new facility around diagnosis and treatment of cancer with no waiting rooms at all, and where patients who are admitted into the ED next door who are oncology patients are assessed in partnership with their oncology consultants at any time of the day or night. There was a very interesting article recently comparing Quebec emergency departments with emergency departments in Finland, a slightly unfair comparison, given Finland have a door-to-needle time for thrombolytic treatment of 20 minutes, when the average is about 3 to 4 hours. But a very interesting article. I don't know if it exists in English, but it's a great article, and stick it in Google Translate, you'll be okay. And then finally, the Nordics. Denmark and Sweden in particular have the concept of a patient hotel, and I've stayed in several of these when visiting hospitals and customers around Denmark and Sweden. And these are there principally for the accommodation of relatives, but also increasingly for moving patients immediately after surgery, and particularly orthopedic surgery, into these facilities to de-hospitalize their care. The concept of a patient hotel is fundamental to the way the the Danes and the Swedes consider healthcare. So some really great experiences, but again, thank you for this morning. So I'm going to have to go really quickly because I understand I'm between you guys and lunch. And given the most important part of the patient's experience is do no harm, I don't want to impose harm on you by disrupting your lunch. So I'm going to go very, very quickly through these slides, Phil, in French. Okay. All right, we're going to look at privacy legislation across the European Union. And it matters. Privacy matters, and that's not a facile pun. And as data becomes more liquid, as citizens who happen to be patients, as citizens who are caring for patients, the data that you store, the data that you accumulate through various types of emerging technologies is becoming more and more liquid. And so privacy is going to become even more fundamental than it already is. And it's going to continually stress the regulatory frameworks that we have in place. And the final point I make at the end of the presentation is that the disruption of technology, we always think of it in terms of disruption to the way we deliver healthcare and to business models. It's actually going to disrupt legislation dramatically, with an increasing focus on patient care. I'll skip that slide while we move on. So the European Union is a little bit like Canada, only smaller. Okay? It is a federation of member states, all of whom have their own personalities, their own languages, some don't like each other, etc., etc. Okay? So I'm always struck by how similar Canada and the European Union really are. And when we look back at where our legislation in Europe comes from, it actually goes back to 1948 and the Universal Declaration of Human Rights from the UN. And then in 1949, the establishment of the Council of Europe and the Convention for the Protection of Human Rights. And this is where all of our patient legislation comes from. And I invite you to look at where yours comes from. Almost certainly the same kind of trajectory. And the rights to health and social care were enshrined in 1961's EU Social Charter. The first direct references to the rights of patients in health and care settings came about in 1997 through the Treaty of Lisbon, and important legal constraints imposed on healthcare delivery organisations through the Charter for the Protection of Human Rights and Dignity. The 8th article of the Convention on Human Rights establishes the right to privacy, privacy in your personal life, extended later on through the Charter of Fundamental Rights, and then Article 8 on the Data Protection Directive, explicitly preventing the processing of personal health data concerning, amongst other things, health, social care data, with some interesting qualifications, notably the concept of national law and national bodies, which has implications for the second half of my presentation. And again, a not dissimilar situation to here in Canada. You have federal legislation, then you have state legislation. And these protections, enshrined in the Data Protection Directive, apply to the use and disclosure of data for the purpose of what I call tactical healthcare delivery. The patient is ill and in front of us, or for research purposes, the concept of secondary use, which I'll talk about in a little bit, or for the obligations and justifications for disclosure not related to healthcare. And this is an emerging and challenging concept of the commercialization of patient data. And I'll come on to that a little bit more later. But legislative frameworks are only ever that. They are frameworks. And there are plenty of real-life scenarios today, and we'll hear many throughout today's proceedings, where current legislation is grey. Disclosure after death and the nature of true ownership of data and my right as a citizen to access my data are significant considerations. And with the increasing burden of elderly care falling on younger relatives, the nature of consent and confidentiality between relatives who are carers will become a major concern, and we will see many interesting test cases. In the absence of a common EU-wide patients' rights legislation, the EU sets out a legislative framework, and directives are instructions to member states to implement the legislation in their context. And I thought this would be quite interesting to look at how varied our countries in the EU really are, and maybe relate that back to your own Canadian national and provincial experience. So we're going to look at the right to informed consent, the right to have access to a medical record, the right to information concerning a patient's own health, and the right to privacy. And I've only picked 4 countries. I've picked Belgium because it's at the heart of the European Union, centred in Brussels. Belgium has a patient's rights law established in 2002. It does not supersede or extend the right to privacy enshrined in the Belgian constitution, which was established quite some time ago. Interesting. Belgium, like virtually all member states, does allow for something they call the therapeutic exception, where care providers reserve the right not to disclose all information to a citizen. It may be based around mental health diagnoses, for example. Denmark is often perceived to be the leading health informatics society in the world. They have had universal GP and consultant access to patient results for about 15 years through the Medcom platform. So it is a very sophisticated informatics society. It's a very sophisticated technology society as well as Denmark. But the Danish Health Act, again, does not extend the Danish constitution with regards to communication between, or does extend, sorry, between secondary and primary care, not involving the patient. Consent to share does succeed to the individual. So a patient may choose not to have medical history divulged to relatives post-mortem. And years ago, when medical records were paper-based, the concept of perpetuity was not significant. But today, with electronic medical records and the very cheap availability of storage, perpetuity is going to become an increasing concern and challenge for us. Finland, my favorite country, actually. They have had electronic records in primary and secondary healthcare for over 25 years and are astonishingly gifted informaticians. They have the oldest patient rights legislation anywhere in the world, with the right to privacy enshrined in a separate Act of Parliament, not as part of the Finnish constitution. And although I've worked in Finland a great deal, even I was surprised at that. As a little sidebar, what the Finns, healthcare in the Nordics is administered at municipal level. Social care in the Nordics is administered at municipal level, so it's the same organisation that manages health and social care. And the Finns are embarked on what I think is the most ambitious and brave project I've seen anywhere in healthcare in 20 years. It's a full integration of health and social care across the 360-degree continuum. It's going to be very interesting to see how they manage it. It's the biggest change management project I've ever seen. The United Kingdom. We have no specific act describing our rights as patients. Not surprising for a country with no written constitution or Bill of Rights. With consent deferred to the General Medical Council. The Data Protection Act, however, does safeguard the use of personal data. Though the nature of confidentiality between patients and doctors is governed by the common law. And so we see that across the EU, the legislative landscape is a very complex one, with EU legislation derogated to a greater or lesser extent to the various member states. And so what are the challenges for us as we move into the realm of digital health? Healthcare services at a distance, whether it's you as patients or consumers, or carers for relatives at home accessing information, whether it's information moving outside of national boundaries for a higher quality, lower cost service. E-health is a very broad term and a bright new future, I think. But it's e-health without borders. Almost all of our legislative frameworks today refer to national law. And yet the EU is a common market. Patients and their information have no borders. The concept of medical tourism in the UK or in Europe is very, very strong. Where expertise is on a geographic region and can be used to drive higher quality at lower cost and facilitate better access. If you can use doctors based in India or in Australia, where it's their daytime and it's our middle of the night for turning around radiology reports, why can't we? Because currently our legislative frameworks do not allow patient data to exit EU territorial boundaries. And it's this disruptive nature of technology and its incredibly rapid propagation through new business models that will stress our legislative frameworks in ways that we can only vaguely depict today. And as a good example of service at a distance, and our existing legislation being cumbersome, telemedicine can be considered a health service and an information society service. So health services are legislated at member state level, but the EU e-commerce directive provides a legal framework for remunerated services at a distance. So to paraphrase the 1980s US comedy Soap, confused? You will be. I certainly am. So let's look at some of the more challenging challenges when interpreting the Data Protection Directive and its major obligations with regards to e-health providers. Legitimate purpose. The concept that data can be shared and used for treatment or the management of care service. But we all agree that patient networks based around conditions and diseases are great ways to generate behavior change. But in terms of sharing data across those networks, and it's your data, Currently, our legislation does not provide mechanisms for that type of sharing to take place. Secondary uses of data. Notice, secondary uses are difficult to define. And with the emergence of part and full sequencing technologies, impossible to predict. Our concept of notice for dissemination and distribution of data will need to change. And how long will it last? Will it supersede the life of the individual? And there's an interesting intersection here with biobanks, and I'm sure everyone knows what a biobank is. If you don't, it's a longitudinal sample, tissue sample, for driving research. Patients are enrolled into a biobank. They have certain types of tissues stored in a biobank. How long are we allowed to keep that physical specimen for in association with the electronic data that we have when we begin to sequence some of these samples? The concept of notice and how we convey accurately and in an informed way to patients what we're going to be doing with your data is very complex. Purpose limitation is laudable, but many of our best hospitals are sitting on an immense natural resource called data, which global pharma needs access to provide the next generation of biologicals, precision medicine. It's unreasonable to constrain our best researchers, our best talent, from engaging in a commercial way if ultimately it benefits patients through better research, better facilities, and of course, better precision treatments to market faster. So purpose limitation will cease to be suitable for purpose. Access rights. All data, notwithstanding the therapeutic exception, this is going to get very complicated. All data in an electronic patient record, everything. There's the emerging concept of augmentation and the ability to instrument the human body. Well, how do we manage that? How do we manage people who are using iPhones to monitor their blood pressure and ultimately to monitor their blood sugar levels? This is sensitive data. Is it all data that we're allowing to be shared? Is it all data that falls under the Data Protection Directive? Security. The Data Protection Directive does not apply to data in transit. Storage of data, use of data, data going between A and B? No. Though various member states require their hospitals between primary care and secondary care, etc., to encrypt to a certain level between source and sink. However, as citizens, when we begin to exchange data, and you only have to look at the United States with their blue button application for downloading their electronic medical record from Vista as a US veteran onto your mobile phone so that you can give it to another care provider. How are we going to accommodate those kinds of disruption? And that was a disruption that came from legislation. The US government legislated the concept of the blue button and the universality of an electronic medical record for all veterans. Are we happy to treat our healthcare data the same as our banking data? I'm not. I'm certainly not. And international transfers, this genuinely is no longer fit for purpose. We are running short of certain clinical disciplines. There are countries in this world and in countries in Europe that will run out of certain clinical specialties, radiologists and pathologists in particular. We have to look at using technology to drive new models of operation to support those countries. France is one of them. They're running out of radiologists by 2025, I think the WHO says. So we need to be able to leverage our connected world to provide service innovation. And this concept of international transfers is already not fit for purpose, and it is already being broken. There are DVDs with patient images being shipped to Australia, being FedExed to Australia for patients to have a look at, for radiologists to report on in Melbourne and Sydney. It's already being done. And so, Susan, I hope I went quick enough there. ours is an industry that's ripe for innovation. I always say that healthcare is the last of the great supply-driven industries. Your access to healthcare is a function determined by those who provide the service itself. And all of the industries have transformed to be demand-driven. Services and data centered around the consumer. Ours is the last of the big industries. But it's coming, and it will be highly disruptive. And technology always moves faster than business models. Business models catch up pretty quickly. Legislation is always the slowest thing, and legislation cannot be an impediment to us as we seek to drive down the cost, improve quality and access to healthcare. Thank you very much.
Thank you so much, Mr. Percy, and thank you to both our speakers for really thought-provoking presentations. I do believe we have a little bit of time for questions.
I've been over here for 20 years, worked in the NHS up until that point, and have a sense that there's been a radical change in the way primary care is provided by primary care physicians. And I think we're facing the same thing here in Canada in a sense that fewer and fewer family physicians are making home visits and those kind of things. Is this, in any sense, a partial explanation for that staggering figure that you quoted earlier about emergency room visits?
Yes, I think it probably is. And the problem that we have is knowing just what sort of renewed primary care we want, because we do have a shortage of general practitioners. There aren't enough people coming through as physicians, but it's also, people are very mindful of the fact that we need to rethink the way staff are used, which I think this is a debate happening everywhere. So it's not just, it's not just the doctor, but it's also the way we use practice nurses and other professionals. I think the move at the moment in the NHS in England is really to move away from the sort of single-handed practice to have networked federations. So in a way, preserve what's important to many doctors is their independence status. And yet, if people are working in bigger units, and there's interesting questions about sharing data across bigger units, and we're already tangled up with quite a lot of issues around that as it is. But working in bigger units can have these benefits. But the government is also pushing quite hard to mandate. The government still loves mandating things for everyone to do. So they've just brought in a policy that everyone over the age of 75 should have a named GP. And they're now thinking about how they measure whether this has happened or not. This is about 2% of practices, so this is a real problem. And it feels though, in some senses that might be very sensible, but if it's not the right person or the person is used to, I'm not sure it's one of these reforms that could be a little bit empty, but the logic is that perhaps we need to segment the population a little bit and so when people have complex conditions, that their care is handled by someone who really knows what to do and is prepared to do those home visits and have a very different way of interacting with them.
Thank you. Let's have another round of applause for our speakers.